Cannot hear you, Pastor Simmons. Can you check your audio real quick? No, not yet. Not working yet. Should be an audio function on the bottom of your screen. Nope. Might have to restart. I'm going to bring on our second moderator, Ursula Dennis, just to say hello and open up the program.
Good morning and welcome. This is part 2 of our lung cancer awareness and screening event. I am Ursula Mathis, and we are going to start off with just what our objectives for this program is. Later, we'll bring Pastor Simmons in, and he'll be sure to welcome you all, and we'll start then as well. Today, we are going to discuss test, do not guess, the role that biomarkers and testing in lung cancer treatments. We have several experts with us today, as well as we're going to discuss clinical trials. We're also going to have some patient and caregiver stories, and we're going to have some policymakers that are going to join us on the call today. We can kick this off and we're going to get started. We're having some technical difficulties, but we're going to move forward anyway. We can start with a prayer. And I ask that you just join me in prayer. Lord, we thank you for this opportunity to come together. We thank you for the panelists and the audience, and we ask that this be nourishing and food for all that are listening. We ask that this be educational and that we become advocates, Lord, and that all things we do in the Spirit, in the name of Christ. We ask these blessings in your Son, Jesus. Amen. Okay, so thank you. We're going to jump right into our panel. And as I said, Pastor Simmons will come back on shortly after we after we hear from our panelists. Be sure if you have any questions, we want to first welcome everyone. I would like to welcome, first of all, Lisa. Lisa is from Amgen. She's one of our sponsors for this event. We're going to hear from Lisa first, and then we'll go into our panelist discussion. Lisa is good. Okay, Lisa's here in the chat with us. Lisa, if you can introduce yourself, and that'll be great.
Sure. Good morning, everyone. My name is Lisa Giroyu, and I'm the Director of Thoracic and GI Cancers at Amgen. On behalf of Amgen, I want to thank you for making time to be here today. Amgen is one of the world's leading biotechnology companies, and our mission is to serve patients by transforming the promise of science and biotechnology into therapies that have the power to restore health or save lives. We are committed to advancing policies and practices in support of achieving health equity so that all people have the opportunity to be as healthy as possible. Those of you who participated in the event on April 2nd heard about the devastating impact that lung cancer has on the Black community. I said it then, and I'll say it now, this is unacceptable. And Amgen is working to change that narrative through important initiatives like this one. We're committed to working with organizations like HEAL and Mount Zion Baptist Church to meet patients and communities where they are, to help educate and empower individuals to become informed advocates for themselves or their loved ones. I'd like to thank HEAL and Mount Zion Baptist Church for working together to create such a phenomenal program, and all of you for being here today. Amgen is humbled and honored to support this important work. Thank you.
Thank you, Lisa. And we are honored to work with you as well. I do want to take this moment to recognize our sponsors of this program, Hill Collaborative, Amgen, Phoebe, Putney Memorial Hospital, Grady Health Systems, Morehouse School of Medicine. We also want to welcome our Georgia State Legislator, the Honorable Dexter Shepard.
Happy to be here.
Thank you.
And I'm very happy to be here. And, I like to take this time to welcome everybody into the workshop and the forum, and welcome anybody to the state of Georgia and to what we're doing in the state of Georgia. I'm excited about what we're doing here. Happy to be a part of it. And I guess we need to also just encourage everybody to register for anything for the future, or register for this so that we can give them more information, follow-ups, things like that. But you'll hear more from me a little bit later, around 12 noon or so. But just like to welcome everybody here, and I would just like to thank all the panelists and others right now that are going to be involved for what you're doing for our citizens in the state of Georgia, as well as anybody that might see this anywhere across the world. So thank you so much, and I'm happy to be a part of this as well. Thank you.
Thank you, Representative Dexter. I too would like to echo that. We welcome everyone to the program. We thank you for being here. This is a wealth of information, and we hope that it brings light to the subject, and we hope that it provides you with the resources you need to advocate for yourselves. At this time, we're going to move into our panel discussion. We're going to start with our very own Dr. Adam Jones. Dr. Jones is a board-certified radiation oncologist with Radiation Associates. He's going to present to us this afternoon. Dr. Jones, welcome, and thank you for your participation. If there are any questions, please do not hesitate to put them in the chat, and we'll be sure to get them to Dr. Jones. Thank you, Dr. Jones, for joining us.
Yes, ma'am. Thanks for having me. All right, shall we get going? Can everyone hear me?
Yes, we can.
Good. All right, so thank you all for being here. I too am humbled to take part in this. I'm a radiation oncologist at Phoebe, but participate in multiple events that help raise awareness for lung cancer screening, and modern lung cancer treatment. I'm also involved with our own Lung Watch program. You heard a lot about lung cancer screening at the last event. I work hand in hand with Ursula. In fact, we see each other at least once or twice a day. Also involved as the chair of the Georgia Lung Cancer Roundtable. This year, I'm brought on Alan Pickens. You may have heard from him last time, thoracic oncology at Emory. Also participate in the Georgia Cancer Consortium, and most recently Georgia Core, which I'm also very proud of. So next slide. As a reminder, and I like to just put the purpose of today, what are we talking about in this short presentation? The purpose is to define biomarkers and how these proteins are involved in cancer progression, to introduce the concept of biomarker testing, and to understand the role of testing in the treatment of lung cancer. Next slide. I love this slide. I stole it from Google a few years ago, but what it highlights is the impact and the importance of lung cancer. What you see on the screen left or patient right, that is the amount of lung cancer deaths in an average year. And what you see on the other side is the combination of breast cancer, colorectal, and prostate cancer combined. And what we see is lung cancer is not only that devastating, but it's that important to study and to make advances. Next slide. Just a bit of a treatment history about lung cancer. Traditionally, and admittedly, this is all we had when I was going through training, not just 10 years ago. Surgery, which is involved in removing the cancer, radiation therapy, which is what I do. We have different ways that we attack the cancer, and chemotherapy. And as we know, chemotherapy is a bit of a poison or a toxin that goes into the blood, and it can make the patient quite sick. And I've just snapped an image from Shirag Jani, who's our leader and medical oncology director at Phoebe. Just wanted to add him to our presentation. So next slide. And some of my dates may not be exact, but I pulled this because I've been learning about biomarkers myself. But in the 2000s and 2010s, research led to the development of novel agents to target cancer cells more precisely, with better side effect profiles and better tolerability. And I imagine the scientists who are actually discovering these agents don't quite look like the scientists in your picture there. I thought a little humor would be fun. Clinical trials showed efficacy, they showed tolerability, and they showed that these drugs work. By the 2010s, these drugs came to the market. The FDA started to study these drugs and found that they were safe and ready for prime time. Fast forward just 10 years, from 2010 to 2022, we have an explosion of data driven by bench work, driven by prospective clinical trials with highly complex treatment algorithms endorsed by NCCN, who is our governing body, I consider, in terms of cancer algorithms, which are now available to anyone. So anyone who presents to an accredited cancer center has access to these drugs. Next slide. So in practical terms, what are biomarkers? And I put these in common day language. How would you talk to me if we bumped into each other at the grocery store? Cancer is evil. Why? Because cancer cells are immortal. They grow unchecked. They disrupt the tissue where they sit. They spread, and eventually they overwhelm the body in its normal function. So other terms that we use for cancer are malignancy, tumor, mass, lesion. We sometimes use these terms interchangeably, but to me, they all mean the same thing, something that can grow and spread and cause problem. Cancer cells present usually in a spontaneous fashion, meaning it's just some erroneous act in nature. And typically these things happen as we age. Our body, the same body that God gave us, is meant to protect from this. It's meant to have these repair mechanisms, and sometimes these mechanisms don't work correctly. So DNA, the building blocks of you, the building blocks of me, the same matter that was given to you half by your mother, half by your father, produces something called RNA, which is let's just say a component that's perhaps half the size of DNA, which then tells proteins to be made in a certain way. And those are the actual molecules and building components of your body. Any error in this process can result in overgrowth, can result in abnormal growth. And sometimes if you get an abnormality in one of these pathways that goes unchecked, you can have almost an autonomous or an immortal cell continue to grow. And that is specifically what's going on in cancer. These mutations, or at least the abnormalities, are targeted by scientists to find pathways to treat the cancer. And that's really what it is. Next slide. So scientists have discovered or uncovered these mutations or these abnormalities through years of research. As cancer grows, these mutations become visible. We're able to run special genetic tests, special genetic panels, tests that were not available 10 years ago to identify these abnormalities. The way I see this as, these are identifiers, such as if I'm a Georgia fan, I may fly a Georgia flag over my house. That identifies me as a Georgia fan. Cancer does this in a very similar way. Scientists are then able to target or create drugs that bind as the complement to those receptors in a way to neutralize the cancer. So that is how these drugs work. Dr. Yoon, who is on our panel in a moment, may give us more specific information, but I felt like it was important for you to understand it the same way I do so that we can understand the importance of biomarker testing. Okay, next slide. Success of testing and delivery. Approximately a quarter to a third of all patients with lung cancer will have a targetable mutation. I personally believe this percentage will grow with time. There's a specific type of lung cancer called adenocarcinoma, which happens to be the most common type of lung cancer. We also refer to these as non-squamous. Approximately 50% of those patients have a mutation. Targeted agents are available, and now more available, not just in clinical trials, but available in terms of being FDA approved and deliverable in your cancer center. Novel drugs, targeted drugs, are generally more successful and better tolerated than traditional chemotherapy. Again, this is a treatment option that we have now that we did not have when I was in training myself. So it is extremely exciting for me to be able to watch. Some patients can sustain durable or long-term complete responses to these drugs. Again, sometimes we think about stage 4 lung cancer, we use the term not curable or palliative, but these drugs sometimes produce a durable, complete response. We have patients living years and now some living a decade later who have no evidence of cancer in their body. It's quite remarkable. In general, through multiple publications that I've reviewed, survival rates in certain cohorts have, quote, doubled in the past 10 years with the use of these specialized algorithms. Next slide. This slide is extremely busy. I borrowed this from my friend and colleague Suresh Ramalingan, who is medical oncology, thoracic oncology at Emory. And I'm not going to go through all these mutations, but what I'm going to show you, screen left shows us a pie chart of specific protein mutations that have been identified by scientists. And then the boxes around the slide show us drugs that target these mutations. Every 6 months, another drug gets added to this box. In fact, this slide I pulled from Dr. Ramalingan's presentation 6 months ago, was told by Dr. Yoon yesterday that there was already another targetable drug available. So this is a rapidly changing landscape. And the graph on the screen right simply shows, the curve to the right shows us in an XY graph, the population of the light blue is the population treated with targeted drugs, which means they do better. The average survival is 1 to 2 years greater at every interval on that curve, and that's published data. Next slide. In terms of the stakeholders, we sometimes wonder who's in charge of these molecular markers. We wonder whose job is it to get these markers. And as it turns out, in any hospital system, one physician or one team cannot do all of these components by themselves. We have the proceduralist, that's the pulmonologist, that's the thoracic surgeon, that's the interventional radiologist. They get the tissue, usually at the request or the direction of another physician. There's the cytologist or the pathologist. They are the doctors who are looking at the tissue, determining, is this cancer? Is this a lung cancer? Is this something that we should prepare to send out for molecular testing? Then you have the medical oncologist and radiation oncologist who help interpret the results of these tests. Then you have the nurse navigators who are in between, liaisons between interventional team and treatment team to ensure that the patient gets what they need. Next slide. Lastly, just to give you all the facts, most patients with lung cancer will benefit from biomarker testing. Not all patients, however, are recommended to have testing or benefit from testing, which is why we don't shotgun this test out of the gate for every patient. Sometimes testing is not useful in certain patient populations or is not useful in certain patients with certain stages of cancer. At the moment, biomarker testing is not useful in screening. There are, however, ongoing clinical trials to explore this. Some patients are too sick on presentation to explore this option. Insurance companies require specific criteria to reimburse or to pay for this testing. And if ordered inappropriately or too quickly, patients may be responsible for the cost of this. There are programs, however, that are in place for assistance. However, it is the job of your oncologist and your navigator team to complement each other and to make sure that if you are appropriate for testing, it is done in a way which makes sense and is done in an expedited manner in the best way that can help you. And that's my last slide. And on the back, I have a picture of Tower 1, which is our cancer center. And I guess at the moment, Ursula, we could perhaps move into the panel discussion. Dr. Yoon is also available, who I openly told him earlier that I would defer to him on all technical questions of markers and testing myself. I'm a simple radiation oncologist, but I do understand it to some degree. Thank you.
Thank you, Dr. Jones, for that presentation. And thank you for putting it in layman's terms so that we can all understand it. and know what questions to ask. I would like to introduce Dr. Yoon. Dr. Yoon is also with Amgen, and he's going to share some comments with us. And then I do have some questions from the listening audience and from the panelists that I would like for you all to ask. Dr. Yoon?
No, thank you, Ursula, and thank you, Dr. Jones. Great presentation. Dr. Jones, I think, covered it extremely well in terms of what biomarker testing is and why it's important. As a drug company, we want to make sure our drugs get to the right people and not to folks who shouldn't get it, and to the folks that could hopefully benefit from it. And so because of that, we're big advocates for biomarker testing, because what it allows is a personalized treatment option for patients. Everyone's cancer is different, and we want to make sure if our drugs are getting to the folks that should get our drugs based on what their cancer looks like. And the biomarker testing enables that. And that's why it's a big passion of ours, big passion of mine, and the work that I do at Amgen in helping to help folks understand what testing is and why they should get tested and when they should get tested based on their cancer type.
Thank you. So for the panelists, what are the most important questions a patient should ask their healthcare provider about getting biomarker testing?
Yeah, so Dr. Yoon?
Please, Dr. Jones, go ahead.
Yeah, so I'll just say generally, great question. So sometimes I have the luxury of being the first physician to meet a patient, whether it be in the hospital or as an outpatient. And this question comes up actually most of the time. Now, usually we're focusing on, okay, how do we put out the fire? How do we neutralize the situation, get as much information as possible? So sometimes it's a matter of confirming the diagnosis, getting a sense of how extended or how extensive the disease is, getting as much information about the patient as we can. We like to study lung function, liver function, kidney function. We like to know, hey, is my patient ready for what's coming? And out of the gate, we like to assess them. If a patient has advanced disease, if a patient is fit for treatment, absolutely, in my personal opinion, molecular testing should be done up front. There are some rules that, let's just say CMS and Medicare dictate where these tests cannot be ordered while the patient is in the hospital. Hopefully that'll change one day. So what I'll do out of the gate as well is I'll snag one of our navigators, and we have specific navigators for lung cancer and for lung screening at Phoebe, and I'll say, hey, tag on to this patient. Make sure the moment they're discharged, get with the oncologist, and I'll usually go ahead and make a phone call. And I'll say, hey, our patient is coming. And while they're in limbo from inpatient to outpatient, we'll make sure that test is ordered. So it's really a customized decision. I never want to be in a situation where we have a test ordered that maybe was inappropriate, or maybe my patient's going to see the bill for it, and perhaps it shouldn't have been ordered. So I take that very seriously in terms of as an ordering provider.
Okay, thank you. Are there any specific health conditions that would make a patient ineligible for the biomarker testing?
I think from my view, it depends on where the patient is in their journey, right? It depends on where they are in their cancer journey. I would say for the most part that what procedure is required is the biopsy, and there are sometimes risks with getting tissue from a patient, so they need to understand those risks. There's other biomarker testing that can be done by drawing blood from a patient. And so I think patients, based on their condition, should determine with their doctor whether it's best appropriate for them to get another tissue biopsy or take tissue out of the body. But blood is always fairly easy to get. But I think it's a decision that they should make with their patient or with their physician based on the potential risks that can be associated with the procedure to get the tissue or the blood from them.
Okay, thank you. So my question is, why isn't biomarker testing like the first go-to thing for early detection then? If we know that it's beneficial to the patient and we know that, why isn't it just like the first thing that we think to do?
So from my perspective, I'll just say, as we see more screening, we see more early stage lung cancer, and which is great. You know, we were shifting the stage, and we see that in every model of lung cancer screening, and that's what we see at Phoebe. So as it turns out, we don't have the data right now to say that patients who have a stage 1 lung cancer who undergoes surgery has any benefit of any form of adjuvant systemic treatment, or whether it be targeted agents or chemotherapy. Now, down the road, Dr. Yoon, I would say 3 years from now, we may find that there is some benefit. So at the moment, because we don't have a known clinical benefit, we kind of ask ourselves, should we even be asking the question clinically? So those are the patients who probably don't need it. In other instances, I feel like it's worthwhile to sit and talk with the patient. I have some patients who will immediately shut down the concept of any form of treatment. And maybe it's because they're scared, maybe because they're uncertain. So I find it really valuable to talk to the patient and get some insight before we even go down a journey. Last thing I want to do is have ordered $20,000 worth of imaging and tests, and then the patient show up and say, oh, well, I didn't want any of that anyway. You know, I'm going fishing. You know, I've heard stuff like that. And then I feel like I've created a burden on them and the healthcare system by even ordering tests. So I feel like it's a personalized decision, yet to reflect on my slide, most patients will benefit from testing.
Okay. My last question that I have is, why is biomarker testing not readily available for people of color who are diagnosed with lung cancer?
I think it should be readily available for all. I think that's the overall answer. And you know, if you think about what Dr. Jones described in his slides, if you have a certain type of cancer, I believe the standard of care based on guidelines is that all patients, regardless of where they are, who they are, what socioeconomic background they come from, should get offered biomarker testing for the type of cancer that they have. And we as a company as well realize there's a diversity gap here as well, and we're trying to address that through education, through funding and things of that nature. But in principle, if you have adenocarcinoma, one of the cancer types that Dr. Jones mentioned, and you have an advanced stage of that disease, the standard of care per the guidelines, the NCCN guideline, is that all patients, unless there's something with their condition that doesn't makes it where it's not maybe advised, should get or be offered biomarker testing as a choice.
Okay, thank you. Thank you. I know I said I had one question, but I do have one more question to ask. And that is
Ursula.
Yes.
Ursula, could I comment?
Please.
Could I comment on the previous question? So
yes.
When I hear about inequities and access issues, from me, it all comes back to it. So I just use the term access. It all comes back to access. You know, as a cancer physician at Phoebe, I have the luxury. I mean, thank God I work for such a, let's just say, a humble institution. I have the luxury of giving standard of care treatment, the best treatment, to the gentleman that comes in with the pack of cigarettes in his pocket, who doesn't know anything about anything. I mean, literally, I have some patients who don't have a primary doctor. I mean, I treat their cancer, then I refer them to a primary doctor. So for me, it's all about access. By the time they hit my door, they get standard of care, whether it be mine, Dr. Johnny, Dr. Krawicki, Dr. Tongle, whoever. So I think the real problem, and this is something that we're trying to address in Project Elevation as well, and I know Dr. Simmons that's his house, but it's, hey, how do we do more than just create a test? How do we bring access to the individual? So for me, if my average patient who doesn't have access presents on the ventilator in an ICU with a cancer the size of a baseball glove, versus the patient with access who presents as a screen cancer, which is cured 75% of the time, there's your disparity right there. I feel like as a treating physician and as a person that creates drugs, all I can do with folks is when they come to me. It's what happens before then that creates the disparity. So for me, it's access to primary care physicians. It's access to screening.
I couldn't agree with you more. And that's exactly where I was going with my next question. So you answered it. Is that, how do we break down that barrier? How do we gain access to care? How do we create avenues and revenues so that disparities are decreased? And how do we create access to screening? And thank you for answering that question.
If I could kind of go a little further. So Amgen sponsoring this event. And it was great to hear from our Amgen leader out of the gate. I'm dropping her name at the moment, but that was perfect. Yes. That's destroying a disparity, whether it be through a church or through any civic group. For me, it's Phoebe standing up a screening program. It's for me, Phoebe telling us, hey, we're willing to give you 100 free screens. In fact, we're putting components into place now where we can do where we can take self-referrals for screens. It's not that we want to take the conversation out of the hands of the primary doctor. It always needs to be in the hands of the primary doctor. But if I can take a simple phone call and enroll a patient in a screening program, I've broken a barrier right there. And that patient should be screened annually. So for me, it's all about how do we get the information into the hands of our brothers and sisters in the community so that we can come to the table.
Yeah. Completely agree with that. I mean, I know we as a drug company and drug companies in general have to do a better job as well, right? In ensuring that we're funding efforts like this to educate the community on the disparities, on the issues, and what the standard of care should be for all patients.
I agree, and thank you both for your perspectives. Is there a difference in the biomarker test that you can get in the hospital versus in a private physician's office versus, is there a difference in the biomarker testing?
No, I think the standard of probably best biomarker testing to get across all lung cancer patients who have advanced disease is a test called next generation sequencing. And so it's a test that looks at DNA across multiple different biomarkers, the ones that Dr. Jones described. And those should be available in the hospital via, in the doctor's office. That can be ordered there. And that's the type of test you want to get ordered regardless of the setting. And it could be using tissue from your cancer itself, or it could also be using blood that can be drawn from you.
Okay, thank you. We're going to conclude this portion of our program, and I think our key takeaway from this portion of our programs is test, do not guess, which is what the theme of this part of the section was, but also in order to know your status, you have to be screened. So that's our first step, is getting to a screening program, getting screened for your lung cancer, knowing your risk, knowing how to follow up and how to advocate for oneself. I really do appreciate you, Dr. Young and Dr. Jones. Thank you for taking your time to share this valuable information with us. Should we have more questions, I'll be sure to direct them to you, get them to you so that we can get them back to the listening audience in some other type of platform. Thank you for your time today.
Thank you very much.
Thank you.
Thank you. So we're going to segment to our next portion of the program. We're going to bring back Pastor Simmons, and we're going to talk about diversities in clinical trials. Thank you for joining us, Pastor Simmons.
Thank you, Ursula, so much for picking up when we had technical difficulty. And let me just say this real quick. On behalf of the Mount Zion Baptist Church and the Hill Collaborative, we want to thank all of our panelists. Ursula did an excellent job of that. But personally, thank you. And to everybody who's watching, thank you. And let me just ask you to do this one thing for me. If you've not done it already, invite someone to join us right now. Take a moment, text someone, call someone, send a link, whatever you have to do. Help us spread the word. And again, I can't say enough about the Hill Collaborative and their support and coordination for this. Quinn is my MVP. Okay, let's jump into my panel, and we're going to look at diversity in clinical testing, clinical trials. One of the ways that we change the face of lung cancer in our community is by improving the quality of treatment. And one of the ways the quality of treatment is improved is through clinical trials and testing. What are the medications that can best treat this person, that person? What's the best method? How do you give it? How do you administer it? All of those questions can be answered in clinical trials, and then that medication or that treatment model brought to the general public. And one of the issues is, while we as African Americans have high numbers in terms of lung cancer, we don't have high numbers in participating in the clinical trials and testing. And we need to change that. And so to help us to do that today, we put together a wonderful panel to give us information and insight into how the clinical trials work. And then we're going to have a person who has actually participated in a clinical trial. And so our panelists today consist of Dr. David Shepard, who is assistant professor of the Department of Hematology and Medical Oncology at Emory University School of Medicine. Our second panelist, Keisha Mansfield, who is manager, clinical research, genetics, prevention, and wellness at Phoebe Putney Memorial Hospital. and then a colleague, Reverend Moses, who is a clinical trial participant. And to our participants, welcome, and we thank you for being a part.
Yeah.
And I want to just open up with our first question, and each of you, any of you, just feel free to answer. And the first question, what are some reasons African American patients refuse or are hesitant to participate in clinical trials?
I'll go ahead if anybody wants to jump on it. I mean, I think that there's a number of reasons that African American patients are less likely to participate in clinical trials. We generally try to group them as, system factors, physician factors, and patient factors. Patient factors would include things like poor access to quality healthcare. Not everybody can live near Phoebe Putney Regional Hospital. It's a great blessing. You guys have that type of hospital system there. Cultural and language barriers are often an issue when patients are getting offered a clinical trial. There's issues with levels of understanding. Sometimes clinical trials actually cost a lot to the patient to be involved in. More frequent laboratory testing, more trips to the doctor, and there's no financial incentive. And I think another thing that was slightly alluded to last time in terms of patient factors was performance status. So if patients show up in a later stage of disease, as the last gentleman was alluded to, the baseball glove size tumor, and they're on the vent, their performance status is not such that they're still an appropriate candidate for clinical trials. But I mean, at the end of the day, we still have to do something about this, because at 13% of the U.S. population, African Americans only make 3.1% of participants in clinical trials. So that's 22% of the expected level. And, the huge problem with that is clinical trials are supposed to be, the gold standard of how we decide what treatment is best. And when we perform these trials and there's significant underrepresentation of any ethnic group, you don't really know how that drug might benefit that ethnic group versus the majority of the patients in the study. So you've got a huge kind of knowledge void there just due to low enrollment. If we were talking about biomarkers, in New England Journal of Medicine earlier this year, there was a study. It was a small accrual study. There was 99 patients on it looking at targeted therapy for lung cancer. There was only one African American patient. So, you've got 1%, of the study, and that, 3% tends to pretty much go across the board. And I think that once we overcome some of these other issues like language, trust, communication, we'll be in a better position to get more enrollment and educating patients to advocate for themselves. Trust is a huge issue. Patients tell me all the time they don't want to be guinea pigs. They talk about the Tuskegee syphilis study, which was an absolutely atrocious study that took place over 40 years. But it wasn't really relatable to clinical trials. The more we, if we actually educate ourselves on it, it wasn't really a trial at all. They were not treating people. So I don't think it's a reason to, I think it's time to kind of start trying to move on so that we can better benefit ourselves. And I'll let somebody else jump in.
Wow. Thank you, Dr. Shepard. You hit on a lot of it. The main one, when you said the mistrust, it was like a big elephant in the room. And I'm glad you reiterated the Tuskegee, because you're right. A lot of us still today don't understand that the Tuskegee wasn't a clinical trial. It was horrible, of course, but I think we didn't communicate it well, because it's still out in the community now. They're not going to do it. They don't trust it. You can relate it to even some of these COVID vaccines, that they're trying to harm the minorities. And so we have to overcome that through, I think, education and more access to the knowledge. And that what brought me to get involved in a clinical trial, because I was working in an organization at the time, the Georgia Cancer Coalition, when Governor Barnes decided Georgia needed to step up in cancer and come up with more cancer research. And I was in the beginning of all these conversations, being around investigators and researchers, and I started learning. I wanted to know because I lost two family members, my mom and sister, to cancer. And my sister died young because, again, she was afraid. She didn't trust everything. And by the time I got involved, of course, the cancer had spread it a little far, and we started trying things, but it didn't work. So I had this desire. I wanted to know. It was just too many people telling me, oh, I'm not going. I said, you found a lump. I don't want to know what it is. I just don't want to know. And so I began working more in the community around that, and even in some of the faith organizations and churches to help us understand we need to be a part of it so we can get better data and results. So a lot of it is mistrust, but I saw a lot of it was lack of knowledge. Even if we wanted to take them for access, they were afraid. And I don't have the answer to all of that, but I knew I was not afraid once I got information and asked questions and got around other people, and they were not afraid to address some of our fears. You can be afraid to address the fear you have. So, I think you hit on a lot of the reasons why we don't do it.
Okay. Let me just add one thing there. Then we're going to move to a second question as it relates to the trust piece. I had an exam at a large hospital, and then all of those requests came from the hospital. And of course, I did not trust the hospital system. And I think who it comes from matters. If my primary doctor that I trust had asked me, my reception of that invitation would have been totally different. Okay, second question. Should patients talk to their primary care physician to determine if they are healthy enough to participate in a clinical trial? And anyone can take a stab at that question.
I'll go again. So it's always good to talk to your primary care physician. In particular, the older we get, the more it's important to get an idea of overall how well you are before you do any sort of treatment. In particular, chemotherapy. We call it a geriatric assessment. So, in older patients, we'll actually send them back to their PCP on occasion to, evaluate for their fitness to undergo treatment. For younger patients, it's not typically so much of an issue to where I would send them back to their primary care doctor. If, for example, someone had a specific heart condition, if you showed up with a heart arrhythmia like atrial fib, I might send you to a cardiologist. But what I do as the medical oncologist is gauge fitness to a great extent myself. I don't really expect your primary care doctor to be able to identify the potential toxicities of the drugs that I use that they are not necessarily familiar with. I always encourage a relationship with the primary care doctor, just as Pastor Simmons alluded to. Patients, when they are very familiar with someone, tend to accept information better. But clinical trials, and this is, I think, sometimes a deterrent, both on the physician's point as well as the patient's point. There's a lot of information to gather to understand the fitness you need, what laboratory values. So, for example, if your kidney function is off by, 5 cc's per minute or 5 millimeters per minute of urine, you're making less than standard for the trial, you might not be a candidate. So it's really the person that has the access to those rules for each individual trial that does the best job of screening patients and determining their fitness.
Okay.
And I'll chime in also. Each trial has an exclusion and an inclusion criteria. So if anything, if you do not meet any of those criteria, especially on the exclusion criteria, anything that it applies to you on the exclusion criteria, then you screen out. And that part of the informed consent should be understandable to that individual, so they know if they meet any of those criteria as well. And whoever is over the clinical trial, the principal investigator, the clinical researcher, they're in charge of making sure that exclusion and inclusion criteria is very strict, so that we don't include people in the trial that should not be included in the trial. And it's also the responsibility of the clinical staff to go through that criteria to make sure the patient meet that inclusion criteria. So there's a lot of work that goes on in the background, looking at your medical history, and pathology reports and those type of things. That medical history, that preliminary medical history, is very important to judge whether or not you even qualify for that clinical trial.
Okay. Let me ask this question and one more. We've got about 5 more minutes. So here goes. So during the trials, patients are asked to sign consent forms and other types of forms. What are the legal and safety protections for people who participate in clinical trials, based on the fact that I'm signing these forms, giving them permission to do ABC? What kind of legal protection do I have in this whole process?
So I'll answer that. The informed consent is written in a way that anyone that reads it should be able to understand it. It should not be at a high level clinical language that the layperson cannot understand. You should be able to read it and understand what the clinical trial is all about. It should list all the benefits of participating, the criteria if you don't participate, what will happen if you don't participate. But it covers all of those issues that should come up, and it's the patient's responsibility to read that informed consent and ask any type of questions that you think that you should have an answer to. And the informed consent process should go over all of that. And the person that is actually presenting that informed consent to you should be able to answer any question that you may have. And if they cannot answer the question, then they should have the contact information of the principal investigator to find those answers for you, or from the sponsor to have to answer those questions for you. But it is the patient's responsibility to understand that document. And I'll always tell people, don't sign it the day that you're given the informed consent. Okay. You should never, ever sign a consent the day that you're presented that consent. You take it home, you go over it with your family, you read it yourself, you do your own research so that you're prepared to ask additional questions when you take that form back. But never, ever let someone pressure you into signing that consent the day that you're presented that consent. That's your right. It's your right, and clinical research is voluntary. And if you sign it, you have the right to pull out anytime that you want to pull out. Mm-hmm. If you feel like you wake up that one morning and say, I don't want to participate in this clinical trial anymore, you contact that institution and say, I don't want to participate, and then they should start the process to take you off of the clinical trial. So never let someone say, well, you signed up, you have to participate, you have to stay on. They're lying to you. You should not stay in it if you don't want to participate. So it's voluntary. Clinical research is voluntary. Mm-hmm. And it is at your discretion if you want to continue to participate or not.
Mm-hmm. Can I piggyback on that real quick, real briefly? Yes. Just I'm 100% in agreement that you don't necessarily need to sign a consent form the day it's presented to you. The point, though, is we're trying to get more people on trials. The window is finite. You might get presented a clinical trial, show up 3 weeks later and something's changed. Mm-hmm. Okay. So, when you take these things home and you're looking over these things and making this decision, just remember that, the whole point of this, someone offered this to you because they believed in their heart of hearts that it would help you. They believed you were a good candidate. And that's why it's important to have a good discussion with your oncologist. And that's why we need more oncologists. We need more diversity in oncology. We need more people that can talk to everyone. When you take that form home, you're also going to run it by your anti-vax cousin. All advice you get at home is not good advice. And that's hugely important as well. So you've got to really filter out who's in your ears when you're making these life or death decisions. So that's all I'd add to that.
Yeah, and if I just add quickly, I recommend we bring people to that meeting. That's very helpful. I've been with 2 other friends. When that clinical trial discussion come, we went in the office 2 or 3 days, and that those doctors and people sit and talk with you. Sometimes when you go home, you it's a different space. I advise you go in, bring your family, the people that your best friend or whoever. Do not go in there trying to make those decisions with all that language, and they'll break it down when they start talking about markers and the side effects, and somebody need to be in there to hear it, and that's going to be very helpful. I just want to throw that in there.
I agree 100%.
All right. One last question and one response because we're out of time. I want us to leave with a takeaway. I come out of this background and say it does no good to hear the word and don't do it. And so our aim here is to increase minority participation in the trials. Give me one strategy that we can take away. Something, we've got policymakers on the phone, we've got providers on the line. One strategy to take away to increase diversity in these clinical trials. Something we're not already doing in it, either one of you.
Is there a clinical trial available for my condition? Advocate for, be your own best advocate.
Okay. All right. Thank you very much. And so now, and again, ladies and gentlemen, if you have questions for the panelists, please type those in the box. And if we don't answer them today, we can get an answer to you. And to each of our panelists, we thank you so very much. And now we're going to move to patient caregivers. And the moderator for that panel is Brandy Bryant. And so, Brandy, we turn it over to you.
Hello. Hi, everyone. I'm Brandy Bryant. I am a lung cancer survivor and thriver, and I will be moderating this panel with, am I waiting on Sydney? There she is. With Sydney, and if we can we're having a little bit of technical difficulties with getting Doug Pompey, who's a caregiver, on, but if we can, we'll get him to join later. So I'm just going to do a quick introduction. My name is Brandy Bryant. I was diagnosed in January of 2018 with stage 4 lung cancer. I don't have a history of smoking, no risk factors, no secondhand smoke, living with anyone who, to have exposure to secondhand smoke or radon that I'm aware of. And it really, for me, just started with a cough that was kind of annoying that we thought might be allergies or adult onset asthma. I was tested for just a quick, the doctor thought I was because I'm a Black woman who is 39 at the time, thought that I may be at risk for sarcoidosis. So I was given an x-ray. It was a little fuzzy. They thought, it might be pneumonia. They put me on antibiotics. Long story short, it clearly wasn't pneumonia. It was cancer, which was very, very shocking. I initially was diagnosed at stage 3B. So I did undergo some chemo and radiation. That did not work for me. And I did have a biomarker testing, which we'll get into later, that showed that I was ALK positive. So I have been on the ALK drug for 4 years now. I mean, the alectinib drug for 4 years now, and I have no evidence of disease. And now we'll go to Sydney, Dr. Sydney Barnett, and she can give her introduction and story.
Hi, everyone. So as Brandy said, I'm Sydney. I was diagnosed in February of 2017 when I was in my medical internship. I am currently a hospitalist, internal medicine hospitalist. But when I was diagnosed, I was 33. I had, as Brandy said, no risk factors that I knew of. I was very healthy, very active, ran 5Ks, realized that, my exercise tolerance was really not where I thought it should be. And I had been diagnosed with a pneumonia the year before and thought that maybe I should check it out with a pulmonologist when I began wheezing. I do have a very strong family history of asthma and eczema and all of that. So, as Brandy, they thought I had adult onset asthma, but when they repeated a chest x-ray, I saw that I still had the same abnormality that I had the year prior when they diagnosed me with a pneumonia. So I requested my pulmonologist do a CT because I figured that there was something in my chest to have the same abnormality a whole year later. CT showed a mass that was actually compressing my airway, and that was the reason I was wheezing. And after a whirlwind of tests, I was diagnosed with stage 4 positive lung cancer within a month. So in the beginning of February, I was fine, just having wheezing. And at the end of February, I was stage 4 lung cancer. Thankfully, they did biomarker testing for me right away. I started on crizotinib right away, and I have been, pretty much no evidence of disease for the past 5 years. And I currently now work, on the oncology floor as a medical internist. So I see people going through the same things I went through. I see them when they're getting they're going through their test for the nodules. I see them when they're getting their chemo and they're getting complications. I see them and have difficult conversations with them about, possibly going into hospice. And I have called time of death for a lot of them. So I've seen the whole spectrum of this disease process, and me being, able to tolerate my targeted therapy has made me forever grateful because, if I wasn't tested, who's to say that I wouldn't be on that spectrum myself? So for me, that's one of the reasons why, I will forever be an advocate for biomarker testing, knowing that information has definitely changed my life. I was able to complete residency without any time off. And, right now living a pretty normal life.
Yes, yeah. Let's talk a bit about the biomarker testing. So one of the questions that I have, which both of us can answer, is tell us about your experience getting the biomarker test. Did you request the test or did your doctor recommend it?
So I am, I'm ashamed to say, and I think that it's not necessarily my fault, but even though I am a doctor, I was pretty ignorant to most of this. The fact that there are biomarkers for lung cancer is like literally a one line in our information when we're studying. I've had like colleagues when we were going through residency, they come up to me and say, "Oh, tell me about your biomarker again," because of course, even going through residency, the only real reason that they are now fully aware of it is because I was diagnosed with it. Mm-hmm. So it's not something that is fully stressed. And I think that when I went to my oncologist, I was probably also not fully, focused. But I didn't really know about the whole biomarker testing. So when I went to my oncologist, thankfully they were on top of it. I went there, they told me you're stage 4, you are, out positive. So they did it right away. So I got all of that information in one neat package with a bow.
Yeah. Here it is. Yeah, mine was, so they told me that once I had my biopsy that they had sent the samples off for biomarker testing. I had no idea what they were telling me at that time, because it was also at the same time that they're telling me that I have cancer. So I'm like,
Exactly.
you know, I heard one of the other panelists say, make sure you have someone with you. That is a pro tip. Always have someone with you taking notes, because you will not remember a lot of the information thrown at you. And it is a whole new world, whether you're a doctor or not.
Yep.
There's a lot of information in each of these fields. So so for me, biomarker testing happened during my biopsy, which was not comfortable, but without the biopsy, I wouldn't know that, you know, the reason why I had shortness of breath was cancer and not asthma or tuberculosis
Right.
or something random that they thought that I may have. So for me, like you said that you were presented with everything right there. So for me, I was diagnosed at a community hospital that I was literally like you. I was in pretty good shape. I was walking to my pulmonologist office for my appointments until until they told me that, oh yeah, you have stage 4 cancer. And then once I started that treatment. But for me, they told me that they were sending my tissue off for biomarker testing, but it did take, and I transferred to a research cancer center close to my home, but just a bigger hospital system. But it took a couple of weeks, like 2 or 3 weeks, for my ALK marker to come back. And I didn't have NGS testing. I think for me, they used the simple FISH test back in 2018. Do you know how long it took for you to get the results of your biomarker testing?
So, like you, I was diagnosed at the hospital that I was working at first. And then they transferred me up to, the tertiary center, and they kind of redid a lot of the tests. So I had like 2 bronchs, and, at first, initially they thought I was like stage 1. So that when they referred me to the tertiary center, they referred me as a possible stage 1. And thankfully, the tertiary center said, oh, let's take a closer look. So they kind of did a lot of the test over. So, I mean, when I tell you I was transferred to the tertiary center February 14th and did my bronch then, I did my VATS February 20th. I had my oncologist appointment February 28th. And February 28th was when I was given that package. So, I mean, it could have been within the same 2-week period, but because everything kind of happened so quickly from the time I was up there, it seemed pretty short to me.
Yes, yeah. As far as with the treatment started, and for me, they already decided to start. My initial plan of treatment was to do 6 rounds of chemo and 30 rounds of radiation, followed by 12 months of immunotherapy. And this is why I also think we need to talk about how important biomarker testing is. At the time, they knew I was ALK positive, but because I was stage 3B when I was initially diagnosed, I did not qualify for the targeted therapy drugs that were available for ALK positive patients. So they wanted me to do the immunotherapy right after I finished chemo and radiation. I had a pericardial effusion during those last couple of rounds of chemo. And when they drained that fluid, they noticed I had metastatic cells there. So that's what bumped me up to stage 4. But the silver lining, if there can be one, is that qualified me for targeted therapy. The other very, very important thing, I must say, and I was in part of an ALK positive group that Sydney and I are both in. And I would see a lot of people who were doing immunotherapy and not doing well. And at that time, they hadn't had a lot of studies showing that ALK positive and immunotherapy do not go together. So it is really, really critical, honestly, before they start a lot of treatment. Maybe you can do chemo and be safe, but you shouldn't do an immunotherapy treatment without knowing your biomarker status. That is number 1. So no matter what, because it can cause, I'm not a doctor, but it can cause hyper progression of your cancer, which makes it worse. So you don't want to, I can't do immunotherapy, as wonderful as it is for many lung cancer patients. It will not work. It will not work for us. So I'm so thankful that I had that biomarker testing and knew that I shouldn't. I was just kind of warned that I shouldn't try immunotherapy as my next step. They gave me the choice between immunotherapy and targeted therapy, and I'm very thankful that I chose targeted therapy, and it's worked very well for me.
I mean, and just to
Go
actually
ahead.
go on that, like it's, kind of sad at the same time, because my aunt was diagnosed with lung cancer literally probably 2-3 years after I was diagnosed. So like probably a year or two ago. And, the first thing I said to her, make sure you get biomarker testing. And she got biomarker testing at the time. I mean, she's still alive, so don't, she's okay right now, but she was diagnosed with EGFR, like exon 20, which at the time they didn't have targeted therapies for. So she had to undergo the same chemotherapy, radiation therapy, and they even, started her on immunotherapy. And as soon as she told me that, I was like, it's not going to work. It's not going to work. It's not going to work. Stop it. Stop it.
Yeah.
And I mean, I did a lot of research. My father and I did a lot of research. And I mean, we, found out that they did finally get a targeted therapy for her mutation. And as soon as we found out, we were like blasting her with the information. Talk to your oncologist about this. Make sure that you get that drug. Even if you have to do a clinical trial to get the drug, make sure you do it. And, thankfully now she's actually being put on the drug. So, we're all grateful for that. But of course, we wouldn't have known all of this if she didn't have a biomarker test.
Exactly. And that's a great segue. I know we kind of already talked about, I want to make sure I don't miss anything. We already talked about how we didn't have any risk factors, but do you have any other, I didn't have any family history of lung cancer, or any cancers that I would worry about. I mean, we had prostate cancer in the family, but are there any other members of your family who've been affected by lung cancer?
No. And I mean, it's strange because, she's EGFR, I'm ALK. We haven't lived in the same country, ever. I lived in Jamaica for a long time and came up here. She lived in Jamaica when she was very young and came up here very young. So she's been in the States for the most, part. And now she lives in England, where that's where she was diagnosed. Both of us are non-smokers. Both of us don't know of any exposure to radon. So anything that you would think would be the typical risk factors, both of us don't have much experience for. And again, she was diagnosed at 49. I was diagnosed at 33. So, even though, yes, she's my aunt, both of us don't have any risk factors.
Yeah.
And I mean, this is not a genetic component for us to say, okay, oh, it's probably genetic. So, I mean, again, it doesn't make any sense. And my whole family was kind of like, whoa.
Yeah.
And that's when not to say they didn't realize before when I was diagnosed, but it really solidified the fact that anybody with lungs can get lung cancer. That is pretty much the number one risk factor. I will never be at risk for prostate cancer because I don't have a prostate.
Yeah.
But everybody has lungs, so everybody should take the time out to kind of pay attention to the fact that just because I'm not a smoker, or I can't get lung cancer, that's false information. So that's the thing that we really want people to know.
Yes. Now, about clinical trials, did anyone on your team ever talk to you about participating in clinical trials?
They did. In the initial stages, I was kind of given the whole array of tests. In terms of, the whole array of medications. At the time, alectinib was there, but it was considered second line. And I think the clinical trial that they offered me was probably brigatinib, but it wasn't at the tertiary center that I was at. It was at, somewhere else. And I was still in residency. And to be honest with you, as people spoke about in terms of clinical trials, I was just like, I don't want to be in a clinical trial. I just want to get a drug that I know what the drug is. I can research the side effects. I'm still in residency. I don't have time to be going back and forth. So I opted not to do that. And I opted to just take, one of the drugs that were offered to me. And, for the most part, I've been pretty good on that drug.
Yes, yeah, I pretty much had the same experience. And just to wrap up, I wasn't offered a clinical trial. I asked about them just to get information, but there were already drugs available that they knew worked. There was really, at that point, no reason for me to use a clinical trial. But it is important to kind of be aware of it when you're diagnosed with something, and just kind of keep an eye on those things to see if there's something available for you. But that is the end of our time. Thank you so much, Sydney. And thank you everyone for tuning into the panel today.
No problem.
So we are now live. We're live with the panel here. All right. Good afternoon. We're glad to be here today to talk about panel policy implications around getting access to these important therapies that were just presented today. I know that Representative Dexter Sharper will be back
Okay,
shortly.
hopefully everybody can hear me okay.
There he is. We can hear you now,
Okay,
sir.
can everybody hear me okay?
Mm-hmm.
Yes.
Okay,
Can you hear me?
Great. I'd just like to welcome everybody to the policy panel. I'm State Representative Dexter Sharper.
You dropped off again. That lets you know how policy works. That tells you something right there. And, policy is important in this particular space. And I know, Maisha, you know this better than most. You're seeing this at the ground level on how individuals are getting access to healthcare and things that are keeping people from being able to access quality healthcare at the right place at the right time with the right provider. And so some of the things that you've been seeing, I guess, kind of give us a little background about what you do and the work that you do in this space.
Great. Can you hear me?
I can.
Thank you so much. I am elated to be here this afternoon or morning to some of you, but I am Maisha Standifer. I'm the Director of Health Policy at the Satcher Health Leadership Institute at Morehouse School of Medicine. Again, I am elated to be here and to talk a little bit about policy implications in the community in which we're talking with and we're talking for in terms of the lung cancer community. And so I told you a little bit about my professional, attributes, but I need to tell you about my personal attributes of being a caregiver and a cancer disparities researcher. Caregiver, meaning I was a caregiver of my husband, late husband, Emmanuel Charles Standifer, who passed last year, on April 11th of last year, due to complications with advanced stage lung cancer. And it was great to be a part of that, listen to the previous conversation and the dialogue to talk about how positive my husband received as cancer treatment in Florida. And so, like I said, preliminary, prior to my husband being diagnosed with lung cancer, I was a cancer disparities researcher and still am, along with a community-based participatory researcher. And seeing a lot of this from that community level of what's happening with cancer disparities, but professionally, it was a great opportunity just to enlighten on what's happening in the community, in the policy field, along with in academia and in research institutions. But then when I was able to be a caretaker, that took it even further, of course, as a personal contact and connection, but along with that journey, that lung cancer continuum, learning the diagnosis to actually the processing of that, especially with an African American male and that population being more disparate throughout the treatment, and also talking about survivorship. So I see all that again from that perspective of being the caretaker, but also right now in being in the research field at Morehouse School of Medicine, we have several initiatives focusing on lung cancer. I'm involved with a lung cancer research project with Morehouse and Grady Hospital. But then I want to talk about policy, and we could talk a little bit more about that. And we talk about some of the current policies and some of the future policies that are on board, and looking at the role of the policymaker and informing and training policymakers. That we have several programs at Morehouse School of Medicine focusing on informing policymakers who don't know or don't know how to, then empowering community scientists. We call them the average advocate, or those who mobilize, those efforts. And I can talk a little bit more about that as we continue throughout our particular panel.
And Representative Sharp, I know you're back, so I turn it back over to you, sir.
Okay, thank you. I guess you guys already kind of introduced who you were. And I also bring about 32 years in emergency medicine, transportation myself. And I'm on the Health and Human Services Committee this 10 years. But we're just looking at some of the things, one thing she alluded to, what is the role of state government in lung cancer prevention? And I'm not just going to have these answers. I want to get the feel from you guys, and you also, Mr. Howard, as a former state legislator, you know how it is and things we have to try to do. My biggest thing has always been prevention. Prevention is the number one thing we have to look at. So I'm going to ask this question to myself and you guys, let you answer kind of first, because I know we're on a time schedule here. But what is the role of state government in lung cancer prevention? So I'm going to ask y'all that a little brief, 30 second or 1 minute answer from you guys, and then I'll probably do the same.
So you can't give politicians no 30-second window. What are you talking about? I'm gonna take 30 seconds just to introduce the question. But if you really think about policy from actually how our government works, we really need to have more of a civics conversation about how policy is made and how people can actually advocate for their own positions. And what we're seeing is that the state really makes it difficult in a lot of ways to have access to these, because it's managing a lot of different resources at one time. So you're looking at not only healthcare, but you're looking at education, you're looking at the prison or the criminal justice system. So all these different things compete for the dollar. And so how do we get the voice of the patient to rise up in that equation is about how people advocate for what they want to have happen. So I think that the state should be about leveling the playing field more than anything else. And right now, I think the state has fallen down on this job.
Yes, and just to echo what what Howard was speaking of in terms of the state responsibility, but local, government responsibility along with federal. Right. And so we need to really look at the mobilization of communities, the informing and the training of community efforts. That's why we currently have housed within Satcher Health Leadership Institute a training mechanism where we inform elected and appointed officials on what's happening in their community and matching them with community-based organizations to really say, hey, this is a multi-sectoral, multi-professional, multidisciplinary effort that we need to inform. And we have several particular cohorts in this training efforts focusing on cancer disparities. And that's where we see our start, informing, educating, training, and then leading up to that advocacy part, which so many are doing and have led in terms of some current policies. We know the American Lung Association, what's happening there and their policies federally, but then we're talking about socially. And so we know that also a role as being whether the HBCU or PWI, that we have to link with community efforts and with political efforts that are, and stakeholders, again, they're not just elected and appointed officials, but those who are informing and working alongside some of those representatives or council members, or even, some, ombudsmen. So we're excited to be part of that.
Okay, and I think to give testament what you guys are saying, that just the mere fact that I'm here with you guys on this panel, being invited to be a part of what you guys are doing, that is a key step. Like you're saying, you just gave a solution to what we need to do. So if I'm involved and I'm right here in the process, then that's going to give me more awareness of what's going on. And that's what we need. That's where it starts. And I'll say my local hospital, South Georgia Medical Center, I was on the city council. They put me on the cancer board, so I was a part of that at the city level. And they say, hey, look, now you're on the state level. We want you involved. And like you say, the local facilities and the locals have to gather together and invite us to come to things so we can be more aware of what's going on. So I think we're in the right direction. So I think more people, more citizens, more organizations need to reach out to their state legislators to invite them in to be a part of what they're doing. Then we will be more aware, because everything I'm getting here today, I'm going to be taking this to the committee, to the chair, and say, hey, look, why don't we allow them to come and speak with our legislators in our committee? So that's one thing we can do. So that's one thing. And when we're looking at this, I have another thing that we want to talk about. What can our elected officials do now to ensure health equity and early detection and screening, access to biomarker testing, and access to innovative treatment and therapies? And as you guys responded to this briefly, I'm writing notes down so I can see what we can actually do and what we can turn into policy. Okay?
Yes. Yeah.
I think y'all tricked me into this to no.
Well,
Go ahead.
I think it's great, Representative, because I think, as you mentioned, whether it be in urban Atlanta or rural South or Northeast Georgia, you are taking that role on in terms of being a very well-informed, well-educated. But then, we know that sometimes it is that tension-ridden community and politician effort, and what happens because oftentimes constituents say, well, you're not doing this, and you take it from a negative perspective. But we're reframing that, right? Just shift the paradigm to say, well, how can we work alongside Heal Collaborative? There, in that when we work with faith-based efforts, we're working alongside racial and ethnic organizations, local, whether it be local academic institutions, but we're taking it a holistic approach to this effort. We're no longer working in silos, because we know what silos have done. We know what they are doing. They're not addressing the issue, as we are continually seeing increased rates. Right. And the rates are continually being exacerbated. So what hasn't been done, we're learning from that. And now it's time to take action. Like I said, we have several, we call them training modules and efforts that are ongoing within our academic community and political based efforts, where we're informing about political determinants of health and social determinants of health. We know that historically how policies have disenfranchised our communities when we're talking about. So we need to understand, let representatives or politicians know that historically redlining has happened. How do we kind of dismantle and readjust and kind of, reimagine what could happen if this was to occur, and especially when we're talking about lung cancer disparities. And we know that it is also socially how we need to address that. So social determinants of health also need to be incorporated into that informing the policymakers, definitely, and stakeholders.
Okay.
Yeah, and I would echo what
Mr.
Maisha.
Howard, you want to chime in that real quick?
Yeah. I'd echo what Maisha said on that. She's absolutely right. First of all, the work that Daniel Dawes is doing over at Moore School of Medicine is awesome. But there are two things I think that the state needs to kind of pick on. One is the pipeline of physicians that look like us on this screen. And so funding for residency slots in this state needs to be pushed up to the front of the wagon, so that we can have more residents in this state, more doctors in the state that are training to be doctors, specifically oncologists. And then we also have to figure out a way to keep them in the state. The other thing that we need to talk about from the other panels, and it's the 800-pound gorilla in the room. And I know that people out here are listening. But think about it, it's about money. Cost of accessing these specialized treatments. If your insurance doesn't cover that, or if you have Medicaid, are these things covered under insurance? A lot of times primary care physicians or specialists, as they are prescribing medications, they look at whether or not the patient can actually afford whatever it is that they're prescribing. And it may hinder them from actually prescribing the thing that they need. And from a policy standpoint, see, the state, the other partner we need to have on this screen right now are payers, because they also hold the other piece of the bag. But the state needs to make sure that that particular barrier needs to be taken down completely so that people can actually access these healthcare.
Right. Thank you. And what I'll mention is where we see it all the time is a lot of the disparities, especially in African American communities. And we are almost to the late point or the late stages of trying to get them help. So I think in some of these programs where there's Medicaid or for one, we need to do Medicaid expansion for one. That will help on the prevention side, because a lot of people in the African American community either they don't have enough insurance, or they're uninsured or underinsured. So it's later on where they catch it now is critical and it's terminal. So I think access to more health care for especially African Americans. And then you mentioned the residents for as physicians. One area where I see we've pushed a lot is in the rural Georgia or rural areas where we need those physicians for sure. And the competitiveness as far as even within the state. You have someone, I don't want to work in the rural area, I want to work in inner city because there's possibilities, financially and also just overall environment. So those are things I know that we're working on. And like I say, I'm writing down a lot of these things because they're beneficial. I want to be able to get you guys to come to the Capitol when we get back in session, or somehow, even if we have a time between now and session, that we can have a healthcare meeting, committee meeting, and you guys can present and give us something to work on before session comes back in, to already have some policy in place addressing some of these things. Another thing, because I know we've probably got about 5 minutes, you guys. Secondhand smoke and environmental factors can also lead to lung cancer. And are there any new policies being considered for reducing exposure to secondhand smoke and environmental factors? Let me mention this. We've done some things about people being able to smoke or not in public buildings. So that's a policy that we took to say, okay, you can't smoke here or there. I've worked with some local municipalities on people not being able to smoke 30 feet of any business, private or public. You have to be 30 feet away from an entrance so that people don't get that smoke. And then we're also working on a lot of things involving the kids. Even when we looked at, raising ages, or even, you can't really say you're doing this, but putting the taxes on, certain things, not making them as affordable to deter, people from, smoking even more. But one thing we are tackling is the youth with these e-cigarettes and honestly, marijuana use, period, smoke is smoke. But a lot of this stuff that we're looking at, we're trying our hardest to put policy in place to get these kids from even starting to smoke, period. So you guys can chime on in that, and then I'll close us out. But my call to action is to get with you guys, even after this, sit down, let's get some policy done, how it is. Get me something that we can present, okay, that will help overall. But y'all just give us a little input on what you think we could do with this secondhand smoke that we may not see right now as it regards to lung cancer.
Yeah, I would say, sir, that first of all, excuse me, you're spot on. So I'm a little bit older than Representative Sharper, although I look younger, but that we're not going to talk about that right now. So,
right, okay.
When I got elected, the legislators used to smoke literally right off the floor of the House of Representatives, and that actually changed in the 2000s. So that tells you how far along we've come. I would agree. First of all, let me just say this: the Georgia Legislative Black Caucus should take this on as a task to do. I know that you all have your annual meeting sometime this late summer, early fall, that we could actually have this kind of conversation. Number one. Number two, it's important that the church be a part of this conversation. It is still, in our estimation, the most trusted voice in our community, and having policymakers and pastors come together to have this conversation is huge in order to get this information out to transform our communities. And then finally, the other thing is that not only secondhand smoke, but think about the environmental conditions around where we live, radon gas, other factors that are affecting our lung health from a policy standpoint need to be addressed. Somebody talked earlier about redlining and communities. We really need to look at how dangerous some communities are, and from a policy standpoint, address those issues so that people are not living in those places.
Yeah, and just to close out, thank you so much to highlight that. Just to bring it back in terms of what you talked about, to really address the youth. I think I'm glad you brought it in, Representative, to talk about it's no longer just smoking cigarettes. Youth are smoking everything else but, traditional tobacco cigarettes. So we know that inhalation in your lungs, anything you inhale in your lungs is detrimental to you, right? So we need to be, stress the harm that's due to that, and really, have some creative ways, and the ways that, I know my medical students that I teach, and in terms of the pipeline training, again, Honorable Mosby, as we were talking about, we need to develop that pipeline and be creative. We are no longer looking at just face-to-face didactic. We are online, we are remote, we are, educating via social media, TikTok, all these creative sessions that we need to understand these platforms. And that's how we need to address it. Going into policy, we need to make sure that data is prevalent. Data. If there is no evidence, there's no problem. And so what we have at Stature Health Leadership and Morehouse is the Health Equity Tracker. We have all of those promoting some of the efforts that we know currently what's in Congress from the top on down is the Omnibus bill focusing on environmental health and hazards, especially with Black women, right? Looking at Obamacare, some of the policies that have enacted and enabled individuals who traditionally were not able to go into get access or get certain services or treatments. People are now able to do that. Even when we're talking about the executive order that Biden passed in January of 2021, talking about health equity. All of this is inclusive. So we know on the federal level, we need to do things. On the state level, it needs to trickle down and be sustainable. So we know that, as you mentioned, the church is great, but we don't just want you to do that one-stop helicopter stop when it's time to get elected and fly back out. We want you to stay in that community, be invested and engage, and create some messages, create some programs that we can continue to have long-lasting impact on future generations. And that is what we do, especially in my role. And I'm looking at educating, informing, and training.
Yeah, and let me just add this one other thing, Representative Sharper. I think that we need to let the people know that they actually have the ability to vote with their feet too. That right now we need for them to do something based on the conversations that we've heard today. That they should go out and engage with their own provider, engage with their policymaker, to understand how they can be more impactful in this space, how to address or access certain healthcare issues that have been brought up in this conversation. That the people don't need to sit here and listen, but they can be an active participant in this process. And we want to encourage everyone that's listening to actually go have a conversation with your doctor and your legislator. You'll find that'd be very interesting.
Right. Well, in closing for us, I appreciate everybody on the panel, and I appreciate this organization. And we have built, alliance here. And I think the call to action for us after this is for us to actually sit down and actually draft some legislation. People got to understand all the legislation doesn't come from the legislator. It's come from organization or some person that's, hey, I think this would be a great idea. So let's do that. And I'm gonna put myself out there to say I'm here and I want to do this, and let's give ourselves a deadline that we can have something ready in the next 3 months or so that we can put our hands on and begin to try to lobby it and get with other legislators and put it in front of others and see what they think about it as well. So I want to be able to maybe 2 or 3 pieces of legislation that I can bring to the committee and try to get it moving. So I'm open to that. So let's make it action. Let's not talk about it. I don't like to do forums and meetings and panels and nothing happens after it. Okay. I want to see
Absolutely.
something done. So I'm going to hold you guys accountable, and I want you to hold me accountable. And we need to hold everybody accountable that's representing the people, because it's all about the people.
Yes, it is.
Thank
Amen.
you so much. And I
Thank
think
you.
our time is up, and look forward to, another part that we can do in the future.
All righty, let's give ourselves a hand. All right. Yeah. Very quickly, let me just say thank you to all of our
Are we
presenters,
over?
and beginning with the biomarker testing panel, then the diversity in clinical trials panel, patient caregiver panel, and then the policy panel. We just finished. I mean, excellent information, critical information that we need in our community, and it's presented in a culturally and relevant way so that we can embrace it as a community. And so thank you very much. And I also want to give a special thank you to HEAL Collaborative. And for those of you that don't know, the HEAL Collaborative is an acronym: Health, Education, Advocacy, and Learning. And they are the linchpin in what you've seen today. They made it all happen. As a lead of Mount Zion, I thank them for partnering with us and making us a part of this collaboration so that we can make our community healthier. And a young lady mentioned how we got to make it sustainable, and Mount Zion is committed to sustainability. We have been here since 1865 doing what we do, and we plan to do it until the rapture. And so we want to be a part of what moves forward and try to make this a better place. Also, want to say to you that there's some next steps. There are things that you can do, that I can do. And we've already had a suggestion about drafting legislation. And so we want to be sure that each and every one of us, you have a slide in front of you, that we do the next things to make this a better situation. And also what I want to say to you is that we have an opportunity here to make our communities healthier and ourselves. And remember, anybody who has lung cancer can catch or have lung cancer. And so let's do this. Help us to improve. There's a workshop survey. You help us improve by completing that survey. There are other resources available, and you can reach out to us and we can share with you how to access those resources. And again, our time is up, and so we're going to close with a prayer. But my final thank you is to all of you who have been a part as listeners and viewers today. And you can help us again if you've not already done it. Those of you that watched on Facebook, you can share this with others even now. And those of you that are watched on YouTube, obviously you can share. So let's make sure that we continue this process. And again, you have slides in front of you. I won't take the time to read them, but they will be there. And let me simply pray. Father, in the name of Jesus, we come now to thank you for this wonderful, wonderful opportunity that you've given to us to be used by you today to share with our audience, with the world, information that can help make our community healthier, to empower us to be advocates for ourselves and for our families. We pray for the HEAL Collaborative and all of the other participants, the organizations, the individuals who've been a part of this. And we thank you for those people who work in the background, whose names have not been shown on the screen, have not even been called. But without them, this wouldn't have been possible today. And so we thank you. Bless us now in Jesus' name. Amen. And we will see you the next time. Stay tuned. We'll be back with more information. Have a blessed day.